Thank you. My question is for Dr. J. I don't want to hurt his last name or insult him. So, Dr. J, if some of the information that we've received is for multiple myeloma patients, we see similar results after VRD and transplant as similar to KRD and transplant. So why would someone want to go with KRD and a potential new drug that we haven't seen a lot of results yet? Is that correct? Moving forward.
I don't know whether you're referring to what I showed. At the moment we have only indirect comparison between VRD and KRD, but indirect comparisons are strongly in favor of KRD. That may have been missed. I didn't emphasize this because it is not necessarily the best scientific way of comparing the regimen, but response rates and duration of responses in KRD without transplant are actually better than in historical RVD with transplant. So it has already advantage in that particular context. And when you add on top of the transplant, looks like KRD is hitting those high rates of complete responses which I showed you, 60–70%. And that to me has been the reason why in our center and many other centers, in top myeloma centers, KRD is top choice, and it's listed in NCCN guidelines in category 2A. The randomized trial comparing KRD versus RVD in cooperative group is in progress, and some of the centers may be participating in it. Will eventually provide that ultimate proof. To my prediction, it's probably going to be showing the superiority. But I want to stress that the study was originally not designed to really compare KRD versus RVD. It was recently redesigned. It has short duration of treatment in KRD and RVD in both arms, just 8 cycles, which is short or long, depends on the perspective. But what we have accomplished in KRD were was the result of 2 changes. First, not only change from V to K, which in the direct comparison in Endeavor trial showed clear superiority of Kyprolis versus Velcade, but also provided patients with extended treatment, which is now emerging as a critical component of improved outcome in multiple diseases. You've heard this actually also for AML today, and in myeloma for sure. Extended treatment with VRD has been challenging because of emergence of neuropathy. It's not impossible, but it's more difficult. With KRD, there are some challenges too, but side effects for people who tolerate the regimen well, and 70% of them tolerate it very well, are so limited that eventually in our original KRD trial we used 24 cycles, and we can go even beyond that. So in summary, there is really no way that I can answer which regimen is better. There is a lot of data to support that KRD is likely better, and many of us have already switched to this regimen. And the reasons why it hasn't been yet proven are very complex, but it was in part because that combination was transitioning between 2 companies. Somehow the critical trial has not been done yet, but it will be done.
There we go.
How do the transplant match statistics look for nieces and nephews?
Go ahead.
I guess what your question is, do we look at nieces and nephews? Is that what you're, traditionally we start closer. We don't do as many haplos, but traditionally when we're looking, so you're referring to haplotransplants, which is an alternate donor, and traditionally we are starting with patients' children because of an age, younger age of a donor is generally preferable, and then we're moving out from there. So there is a chance that nieces and nephews could be a haplo match, but that chance is much lower.
So, what you're referring to is extended family searches. So, because I had mentioned cousins, and so there's not a lot of data. I think there's just a few centers. Johns Hopkins has been doing more of those types of transplants, and the early results are similar to other types of haplo, but we really don't have enough data to know. But the feeling is if that's what you need to do, some centers would do a mismatched unrelated donor or an umbilical cord blood over that. But the data look at least promising, and so some centers feel it is worthwhile to do that extended search.
And if I will jump, even if myeloma rarely uses any transplant from a donor, so it's not particularly my area of what I do for myeloma, but I am part of the transplant group at University of Chicago, and we are one of the centers where haplo approach has been done for years, and we in fact are using haplo cord, which is a very neat technique because it actually takes some of the problems with haplo, which is late engraftment, which opens up for infections with this trick of using haplo first and then eventually allowing cord to in a long run to work. I think I mixed it up when I explained earlier. The haplo takes the cord takes time to engraft, and use haplo initially to just bridge that period, so the patients are for a while protected with their counts recovering from haplo donor, and then eventually engraft with the cord cells.
And the other technique is to grow the cells outside the body, the cord blood cells. And obviously what we're talking about is the fact that the cord blood has very few. I mean, it's umbilical cord from a neonate. There's not a lot of cells, and we are transplanting adults who are sometimes 100 kilograms. So the number of cells we give for transplant is very critical into outcome. So we're able to grow these cells outside the body. We published an international trial a couple months ago showing that it improved survival at 100 days and engraftment, and a subsequent follow-on trial for which there's a phase 3 trial ongoing using nicotinamide to make sure that the cells maintain their stemness, if you will, has been successful, and it's a drug licensing trial for a company called Gamida Cell in Israel. So there are techniques that all of us are doing, and I always say it's great that we're doing different things rather than the same thing, because we'll eventually come up with the best of, and so again, that's pretty much happening at our center.
When do you determine if and when stem cell research or stem cell transplant will be viable for mantle cell lymphoma? Because I'm in chemo right now. I just was curious. And I'm at Rush too. Hi, Doc.
So we'll have the lymphoma doc talk about that, and then I can give some comments too. Dr. Vino?
I thought the question was specifically on transplant, so Dr. Steve would be the best person to answer that.
So mantle cell patients do extremely well with chemotherapy, especially now over the last 6 months or so. A paper in the New England Journal shows that maintenance therapy improves the outcome. So chemotherapy followed by maintenance. And now we have a measure of which patients truly are in deep remission. So whereas traditionally over the last 15 or 20 years, transplant is part of the initial therapy, there's now a National Cancer Institute supported national clinical trial in which patients who are in remission, especially if they're in a deep remission, will be randomized between the rituximab maintenance for 2 years or transplant followed by rituximab maintenance to see, do we still need to do transplants? Because the transplant data is again about 15, 20 years old, in which the Germans showed improvements in remission duration and the kind of a borderline improvement in survival for transplant. That's become the standard of care, especially for younger patients. So we're not sure that we need to still do them because we have better treatments now up front, and fortunately we have a measure of measuring, do you still have mantle cell in your body? And if you do, then you do need a transplant. If you don't, you may not need a transplant. You can just get better with maintenance therapy. So that's a strategy that we're doing nationally through the Eastern Cooperative Group, Oncology Group.
But if I may, I think it's an important broader question for both auto and allo strategy at some point. To some extent, I think we are at the time when everybody, patients, and we are looking for time when this tool may not necessarily be used as frequently as we are using right now. And those are the developments which we potentially should be trying to see and watch. I'm using Transplant a lot. I think it's one of the best tools which we have for multiple cancers, myeloma including. It would be great if at some point we'll say, okay, this is just this small subset of patients we need transplant, the rest doesn't need it, like we do already in AML.
I will give an add-on comment, a caveat, and I think believe it or not, this comes a little bit out of left field, but it has to do with the cost. And it may be a lot cheaper to do an auto transplant than put somebody on, as they're doing in Europe, maintenance with ibrutinib as one of the arms in their trial. Ibrutinib is very expensive. It's about $6,000–7,000 a month, and if you do that indefinitely, as some of these trials are doing, very frequently you'll come up with the cost of transplant within 1 year, and you're still on the drug. So ultimately, we do need to think about what's the cost to society in general. Healthcare is now 17% of GDP, and we can't go much higher in this country. It's felt that if we continue on this rate in the next 30 or 40 years, it will consume more than half of all of the budget. So I know that there's been talk about lowering the cost of drugs, et cetera, and we certainly need to do that. But again, to throw out the caveat that sometimes a transplant, which may cost, the true cost of a transplant may be less than $50,000 versus a drug that costs $100,000 a year. So I think you will need to kind of factor this into ultimate therapies. Would you rather be done with your therapy in 6 weeks with a 0 to 1% mortality, or continue taking a drug indefinitely to maintain the same outcome? And I think we all should be involved in making those decisions.
If I may, because I think it's interesting, again, jumping into your comment and costs. Ultimately, costs will go down in those treatment strategies when we find a cure. If we have strategy, no matter what it is, whether it's allotransplant or autotransplant or CAR-T, which is the one-time, even expensive intervention, and then you don't have to do anything, that's eventually what may bring costs down. And so that's why I would be very careful about not necessarily limiting ourselves in developing certain things in a variety of directions, with understanding that extended treatment with expensive drugs may cost a lot, but along the lines of those developments, we may find, as you've seen today for venetoclax story in AML, that some of the patients you presented that may potentially have eliminated disease and haven't used the big gun. And then even if this intervention, it could be CAR-T, could be small molecules, comes along, that may potentially take away some of the costs, including extended treatment costs.
Dr. J, I've got a question about smoldering myeloma. I understand the protocol has been to watch and wait, monitor blood chemistry for every 3 or 4 months. Is that still the protocol, and are there other things being looked into?
Short answer, yes. For those of you who may not know the subject of the question, smoldering myeloma is the diagnosis of already existing myeloma in a patient, which has, per our criteria, been assigned this particular category when there is no evidence of organ damage, no evidence of immediate progression to risking organ damage disease. And many of these patients, for extended time, depending on prognosis, stay without treatment and stable, and some of them may never even need treatment. So based on these observations, patients with smoldering myeloma in different categories have been observed and remain observed, and NCCN guidelines are still making this recommendation. Nevertheless, there is a lot of research in this field, especially in the category of smoldering myeloma, which we call high-risk smoldering myeloma. There is a lot of trials across the country which are using this particular group to potentially even try to eliminate the disease. Previously, we were giving for this group of patients sort of maintenance not to progress to myeloma. Now there is an emergence, which I like, of efforts to use this particular stage of disease, when disease is more susceptible, very easily responding to treatment, and attack it with the best tools which we have. Spanish, I mentioned that, use, probably misspoken, a KRD and transplant strategy. They will report about those results in long term of how it worked, but the cure was in their objective. They presented at ASH meeting the curative strategy for smoldering myeloma. We'll wait and see. The results are encouraging. KRD and daratumumab, and with or without transplant, is coming as a multi-group effort led by Mayo Clinic, but it's using KRD, our regimen. We will be opening this trial for high-risk patients at the University of Chicago in the next few weeks. So these patients need to understand that may not need treatment, and there is a risk-taking strategy to be treated. But if you use something which may be done for, say, 12, 13 months, and then stop treatment, and if disease is eliminated, and with those strategies, 70% chance of achieving complete response is a good guide to potentially take this strategy. That's something which one can potentially try. But I would not do it outside of clinical trial until we have more data.
I agree with the comments Dr. J made. There are some situations in smoldering myeloma, to answer your question, like if the PET scan or MRI shows a bone lesion, or based on number of plasma cells in the bone marrow. When you do a bone marrow biopsy, you look at the plasma cells, or the ratio of the light chains. Those are some of the time indications to consider treatment. Would you agree?
Yes and no. I mean, in a way, this is the group of patients which until recently we called smoldering myeloma, but by new criteria, one of my colleagues carved the title SLIM criteria, when marrow is 60% involved or more, light chain is ratio 100, kappa to lambda, or there is MRI findings, as Dr. Vinogopal mentioned. These patients have been recategorized as now myeloma requiring treatment in new IMWG criteria. Now, there is a lot of patients in the borderline, especially if they have high-risk disease. I think on case-by-case basis, these patients may be potentially considered for treatment. I'm conservative, even if I make appearance to many that I am aggressive physician in terms of treatment, but I'm very conservative. I don't do anything which is not necessarily yet approved as a standard of care. So in general, I offer smoldering myeloma patients clinical trial if they're eligible. I've treated few and I will continue to treat it. I think this is the direction to go. Disease is more sensitive earlier, and if we have curative strategy, we should be trying it.
I'm going to ask a question about both the previous two. One, I always hear that treatment procedures in Canada and Europe are cheaper than they are here. That relates to the first question about the cost of $400,000 for drugs. I don't know if that's the case for sure or not. I believe you people on the board would know. And then the second part is tying in what you just said there. Aggressiveness is, how aggressive can you be? Is it the doctors or the group of doctors feel as far as the patient and what the outcomes might be per patient? Is it individualized along those lines?
I don't want to occupy it, but it's to some extent related to my comment. It's a complicated question about aggressiveness. I'll start with this one. I think if we have a strategy which shows that you prolong survival, whether it's called aggressive or not, you want to do aggressive strategy to prolong survival, and I think that is always justified for patient who can take more aggressive therapy to do that. There was a time in myeloma that Mayo Clinic have come with SMART guidelines, which have suggested that for good prognosis disease, we can initially start less aggressive therapies. It turns out, it was never validated, that it was not necessarily the best strategy and best approach, as we have learned in the last few years that more intensive therapies help not only high-risk patients, for which in those MSMART guidelines the more aggressive therapies were reserved, but also help to prolong remissions and survival in good-risk patients. So everything has to be looked at in the context of data. If data suggests that this strategy gives you better chance of being longer in remission or surviving longer, if you call it aggressive, that's how it is. But there are some patients who can do extremely well on less intensive approach, especially in diseases where we have no evidence of elimination to cure. And that's always an approach which should be discussed no matter how we approach it. As far as costs, it's a bigger question for maybe my colleagues. I would say one thing. I'm originally from Poland, so I'm kind of European by at least observation and lots of contact. There's a trade-off. Some of the things which they pay for from their national guidelines may be paying less than we are paying here. At the same time, they are rejecting or not approving things which are already available here in the United States, and it has to be something which we are privileged to have here in the United States and remember.
So, yeah, the cost, that's a day right there we could spend on cost. But getting back to the issues relative to the gains with prolonged therapy or more intense versus less intense, I had mentioned this a little bit. You know, many of us are now interested in gathering data from our patients, so-called patient-reported outcomes. And this is being done both on and off studies, because it turns out that physicians are not all that great at estimating how your quality of life is, you know, and we don't spend a lot of time on that, and you also don't want to disappoint us and tell us, you know, about the side effects that you're having with the drugs, particularly if they're working. So our organization and many others, the NCI has made a major effort to develop instruments and tools that we can use to try to understand how our therapies are affecting our patients. These can either be filled out in the clinics, or we've developed a tool where we can actually just send a link to our patients and they can fill it out online. And for instance, we're doing a study now where for myelodysplastic syndrome, we're trying to look at patients who have a transplant for it and have not had a transplant for it, and try to gather data on how their quality of life is either way, to try to understand better. So that's something that is being developed, and I think it's going to be very important that patients like you who are very interested in research allow us, and most people, it shows, are very interested in helping us get these data, because I think it's a very important question. Particularly, there are many therapies that marginally improve survival, even if they lower relapse, and you really want to know how do they affect people's quality of life. I think it's incredibly important.
So if I can make a comment about therapies and aggressiveness or not, it really has to do with a lot of factors. It has to do with the disease, the stage of disease, and the patient factors as far as what we recommend. And we try to do that in an individualized fashion. The clinical trials, I think, will help us guide that a little bit better. And obviously, with new drugs that are more effective in producing deeper remissions, the real question is, how long do you need to continue them, or what's your cost benefit ratio for these added therapies onto current therapies. So I think that we're still learning, but so for follicular lymphomas, people have said the same thing as we're talking about with Hodgkin's disease. Follicular lymphomas, oh, you can never cure follicular lymphoma, so don't bother, do the watch and wait up front. And in fact, the initial trials with rituximab, the first 20 or 30 patients, they showed that those that did the best were those that were earliest in the stage of disease and had the least amount of disease. So we're changing our thinking a little bit about a lot of diseases, but we need a lot more data on this. The smoldering myeloma patients, there's certainly maybe patients who really are kind of close to myeloma that needs to be treated, and then there's the indolent smoldering lymphomas that have very low risk disease. It's almost like an MGUS, and those patients you can maybe get away without treating them for a longer period of time. The question is, which patient of those smoldering patients is actually going to benefit the most? I think that one could even make the argument that those that have just a little bit more than MGUS might be those that benefit the most. So the lowest risk patients might actually be those that were able to cure patients. And we've done transplants now for the last 20, 25 years, and I have patients that come and see me once a year who are out 22, 23 years, have a single transplant, no maintenance therapy, that are still in a complete remission and are still doing quite well. So we need to be able to pick out those patients a little bit better and then go back and say, this is the patient that we should do or not.
Good afternoon. I read a news several years ago about CRISPR technology, wherein a gene chromosome technique used for altering genes. What's the possibility of this technique or technology to be used in repairing chromosomal mutations in blood cancers? And if there is a trend, which among the blood cancers would benefit first?
So CRISPR is actually in the realm of clinical care. Is actually being tested as a methodology in lieu of retroviral or lentiviral transfection of cells to make them CAR T cells, as potentially a way to make these cells and potentially less toxic. There's lots of new techniques that are being developed. We're in the process of developing one ourselves, where we strip away the extraneous cells. When you put cells into a culture, you don't just get the cells you want, you get other cells, and the other cells may be mediating some of the toxicity. CRISPR technology may allow you to get a more pure population, which might be potentially not only more effective, but also less toxic. So those are types of things that are being used to guide therapy to treat genetic diseases rather than putting the CRISPR technology into patients themselves.
Yes, Dr. Khan, in addition to what I asked earlier about the MDS minus 5q deletion, if you stop the Revlimid and you take the stimulating drugs for the red blood cells, is that considered a maintenance then? And how long are they effective for keeping the hemoglobin up? And also, if it isn't effective after a while, do you go back and try the Revlimid?
So there are studies reported where people's clinical experience using Revlimid in 5q MDS, where people do use an on-off strategy where you do the Revlimid for a while and the toxicities become too difficult, so you take some time off, and people have reported that they can have equal efficacy when they resume the drug. So on-off strategies do work in 5q MDS with Revlimid. And the drug, as far as using the erythropoiesis stimulating agents like Aranas, that's when we use it generally, you continue it. It's not really considered maintenance because it's a hormone and it works so long as it stays in your system. And so, whether it's erythropoietin, which is short acting, or Aranas, which is a little bit longer acting and can be given every few weeks, these drugs should be taken continuously until they stop working, and they do stop working, and the duration of response is usually over a year. Some people get several years out of it, and sorry, one last thing I'll just put in there is that if Revlimid stops working, one of the mechanisms that's been identified is development of a mutation in a gene called P53. So that's something that when a patient who's been responding to Revlimid with 5q start to lose that response, that's something that should be looked at as a mechanism of resistance.
Thank you.
Hi, this is a comment. I'm speaking on behalf of my mom, Michelle. She says, I have AML, and I'm so grateful that I have access to all of you wonderful doctors. She's currently at Rush and approved for the stem cell transplant at Loyola with Dr. Stiff. What a change for Chicago in 14 years. And I just want to echo that gratitude to all the collaboration and research of all these institutions working together to be able to solve the problems, because without that, there wouldn't be anything else. So thank you.
I want to pick up on that because I think it is by virtue of representation of all of us from different institutions, almost all in Chicago, and we are sitting together. We're good colleagues, know each other very well. We're doing, as you can see, well, but I think there is room that we can potentially do more. And I always, not only me, many of us think that we can potentially take advantage of this consolidation of power which we have in Chicago and small area and large number of patients, and potentially advance our way of treating different cancers in hematological malignancies. It's just heartfelt comment at this point, but I think we can. I'm very much grateful for this comment from Mark.
Like North and South Korea, huh?
If you don't dream, you won't get it, right? I don't know about this. I don't want to go into political discussion.
Don't go there.
I can tell, being a neighbor of East and West Germany, that it was dreamt and it happened. So those things do happen.
We would be happy to do that, and we've initiated some collaborations. I agree we need to do more, and since we're so close, when you do a new treatment trial and it's covered under an IND, so if the University of Chicago did a trial and they have to get permission from the FDA to do that trial, they become, if you will, the drug company, and they have to make sure that anybody who else does that trial is complying with everything that they said they were going to do to the FDA. And if they did a trial and we did the trial at our place and we were loosey-goosey and didn't do the things that we should be doing, we don't get in trouble, but the University of Chicago gets in trouble for that. So when we do trials, we actually have a trial with TCR cells with a hospital in Portland, Oregon. So we're responsible for that hospital. Doing it a lot closer makes a lot more sense rather than trying to do it long distance. So I would agree, and we should do more of that rather than less of that.
My mother has CML leukemia. She's been on her second type of medication. It seems like the doctor is dictating her doses based on the pharmaceutical company, which she cannot tolerate because of the toxin. What is your recommendation? Is there other things? These medicines seems to be very strong for her.
That's a good question. So I don't know, in terms of the pharmaceutical company shouldn't be dictating the dose of a drug. So the doses are generally dictated by the doctor and the patient. In CML, there are many, many drug options. And those drugs all do have real toxicities and side effects. But patients who are not tolerating one can generally move to another similar drug and capture a response. So when we're looking at our patients with CML, the choice of our drug up front may be a little bit different from doctor to doctor, but the side effect profile certainly comes into play in terms of which drug we're choosing, which dose we're willing to use. And you can reduce the doses of the drugs often and maintain a response. So the short answer is there's a lot of options, and your mom should be able to, with the help of her doctor, kind of figure out a way to get her to tolerate the drug and maintain the response to the treatment.
Okay, interestingly, there are standard drug doses, and that's how the drugs were developed. So for Gleevec, it was 400 milligrams, etc. And what was not done, at least publicly, was that we all metabolize the drugs differently. So I might take Gleevec and have a level of 1x. Somebody else may have it and have 0.5x and actually need more to get the same benefit. And then there are people that might have the same drug and have twice as much in their body. And in fact, there is no commercial test to measure the drug in the person's body. Well, it just so happens that the institution, which is University of Oregon, that originally developed the drug Gleevec with Novartis, actually has such an assay. And I had a patient who got 400 milligrams, and every time she would come in, I go, keep going, you can do this. And she had lots and lots of toxicity. And finally I said, you know what, I'd like to measure the blood level, but I can't. So we sent her out to Oregon. They measured her blood level, and she was in a toxic level. So they lowered the dose to 300 milligrams, and she tolerated it better, and she still got a benefit. And then eventually, 2 or 3 years later, she's off the drug totally, is in complete remission. So indeed, we all metabolize. So when I see a patient like this, what I'll do is sometimes, especially if it's early on, I'll give them a little bit of a holiday, put them back on the drug at the same dose. They still have problems, and lower the dose, and then go from there. And you can measure the clinical benefit by blood tests as far as the PCR. So it may be that's what's happening with your mother.
I just also like to thank everybody for all your research and dealing with the problems.
Thank you.
You still got a lot of years left in you. You're just showing people how old I am.
Can I address this to Dr. Stiff? Knowing what you know today, if a patient who had an autologous stem cell transplant for a complex non-Hodgkin's lymphoma relapsed, would you be predisposed to try another autologous transplant, or would you try to move immediately to CAR T-cell?
So it depends on the patient, obviously, but another autologous transplant we usually do not do. We will occasionally do them for myeloma, and patients that go into a long remission, ideally 3 years or longer, we'll do a second one, but that's not something that we do for non-Hodgkin's lymphoma. As far as whether or not to give them CAR Ts, it depends on which type of non-Hodgkin's lymphoma it is. If it's a follicular lymphoma or if it's a mantle cell, I might be inclined to, unless there's a clinical trial, to try some more conservative therapy. If it's a large cell lymphoma, then I think, again, because that's the FDA-approved indication, and the patient can otherwise, in my opinion, tolerate that, and otherwise meets the criteria set forth for safety purposes, consider that as an option. Not everybody is eligible for that therapy based on the fact that it can cause low blood pressure. So if you have a heart failure and low blood pressure, you're probably going to go into shock, and that's going to be irreversible. So those are the types of things that would enter into the decision making.
Well, thank you, Dr. Stiff, and to the gentleman over here, I can only hope that we'll both be here 19 years, and I'll keep pestering you.
It won't be.
But
the registry did look at, there are very few patients who have had a second course of high-dose chemotherapy and autologous transplant. The registry published this data, again, very few patients, and most of them were in their 30s. So, if there's young, healthy people, it might be done, but it really isn't something that's anywhere near being standard practice.
Is cancer-free and complete remission, are they the same? Cancer-free and complete remission?
To me, yes. In some of the malignancies, complete remission is equivalent of potentially no potential cure, and that's how it is. In myeloma, we don't use, most of us don't use complete remission, we use complete response for presumption that myeloma may not be curable. That's the official line, and that's why we use complete response rather than remission. So there's a lot of semantics there. Even if we declare somebody for ourselves, for our patient, cancer-free or without any evidence of disease, we have to keep in mind that we have tools as we have, and they are not perfect, and we may not always be able to tell that this ultimate goal has been achieved. But based on certain set of data, we can declare it for some cancers, and among them is AML, for example.
I think ultimately whether somebody's cancer-free or not depends on how long they're in that complete remission. And sometimes we see relapses even 5 and 10 years later. So if you go back and say, well, they were in complete remission, they weren't cancer-free because the disease was still there and ultimately perked its head back up. So ultimately survival at a set point in time without relapse kind of is our definition of cancer-free.
Well, it's based on, cancer-free based on the limits of our ability to detect, right? And so we used to use just CAT scans and now PET scans, and we have better tests. And we think they help us predict better, but even people who are negative by the most sensitive minimal residual disease test, there is still a fraction of those patients who can relapse. So that's why we're so careful about using the word cancer-free or cure, just because there's always some degree of imprecision in being able to say that.
For non-gastric, low-grade non-Hodgkin's lymphoma that originated in the parotid gland, are there any new treatments that have been successful in curing the lymphoma?
Okay, so what I heard was a non-gastric MALT lymphoma, is that correct?
Correct, non-Hodgkin's lymphoma.
MALT lymphoma, it depends on which is the location. So MALT lymphomas are typically low-grade B-cell lymphomas that can occur in the stomach, where it may be a little different because many a time it can be associated with a bacteria called H. pylori, and some of the patients can be even cured by treatment with antibiotics, which is a rare situation in cancer, as you can understand. But outside the stomach, when MALT lymphoma shows up, H. pylori is not usually the cause, and the treatment depends on the location. For example, if you have it in the lungs, we call it MALT is mucosa-associated lymphoid tissue tumor, like that. If it is in the lung, we call it bronchial-associated lymphoid tissue tumor, or BALToma. So if it is just an isolated tumor with MALT in the lung, taking it out is the best treatment. You can get very long remission with that. Sometimes MALT lymphoma is in multiple places and causing symptoms. We may want to treat just like any low-grade lymphoma with rituximab or chemotherapy with rituximab combination.
Yeah, it was localized just in the parotid gland. So as of right now, there's no chemo that was recommended. If it's localized, is that correct?
Localized MALT lymphoma in the parotid gland. Typically, if you take it out, you don't need any further treatment. And even if the biopsy and show it, you can, for example, one option is to just give local radiation. That is one treatment, but radiation to the parotid gland has side effects. So one of the options is either to watch it or treat it with a systemic agent like rituximab.
One in the back, Carl?
Yep. You made a comment that wait. Chemo caused an AML. What's the percentage, or what's the statistics on that?
Ask that again, please.
It's rare. Yeah. To be honest, I don't know the exact percentage, but it's rare. It's not a common phenomenon, but it's something that we do see enough where that we see these patients. So I don't know if anybody knows any more details.
Yeah, it's in the single digits. I mean, obviously, it's cumulative over time. What's interesting is that there's data that suggests that it may not necessarily cause it, but these cells may have been there that had the capacity to turn into leukemia that were maybe selected out by the chemotherapy that was given for breast cancer. And we all have those cells in our body. But so that may be more what's happening as opposed to actually mutations being induced by the chemotherapy itself.
Okay, well, once again, I'd like to thank all the sponsors that have helped make today possible, but most importantly, I'd like to thank these doctors. They've given up a solid 7 hours of their Saturday to come out to help you to the best of their ability, and we appreciate the fact that you've taken time out of your day too. We hope you found it worthwhile. We do hope that you will fill out the evaluation forms, because we want to continue to improve this program. Those of you who have been with us know that we've had sound issues in the past. We've had issues. So these evaluations help us improve it each and every time we have this. Follow our progress, allbloodcancers.org. There's lots of information on the website. There's lots of ways for you to get involved as well. But thank you all for coming today.